Hi, everybody, and greetings for our last interview of season 2 of Inspire the Mind. When, as you know, every couple of weeks, we chat to somebody who's really caught our eye in this field of mental health and mental well-being and doing interesting work. And this week, I'm talking to Victor Ugo. Before I go any further, Victor, have I pronounced that right? Is that how I say your name?
Yes, actually, yes, very much better than than I've heard it pronounced in the past.
Oh, well, we're getting off to a good start. So Victor, just give us a little bit of a introduction, where you are right now, who's in your house, what's the weather like? Just sort of set the scene for us so we kind of move away from this kind of blank screen that we all have of computers, just like a little bit about your setup right now.
Well, I'm in Copenhagen.
Okay.
It's -1 degrees now,
Okay.
and I am in my office, and my partner is in the living room watching Big Bang Theory. Yeah, I haven't gone out today, actually. I haven't
Okay.
gone outside today, but I know it's really cold.
Okay.
Not gonna do that.
Okay, fantastic. And so Victor, you're a doctor, is that right? Okay.
I usually say retired doctor, but it works anyway.
Retired doctor. You look too young to be retired. In fact, how old are you? You do look really super young.
I'm 31,
30.
but I am retired.
Okay.
Yeah.
Okay, fantastic. So just let's rewind a little bit. Can we just go back to like your childhood and your upbringing and what led you to medicine, and was that in your family? Just a little bit again, so we have a sense of context of your life and
Yeah.
where the story starts.
So I had a pretty boring, in a typical sense, childhood. I was so used to, getting home from school and picking up a book, a novel, not my school book, and just reading. So I actually started building up a library from when I was 6, up until maybe now. I mean, I haven't been home in a while, but my library is still there. And now I have about 5 shelves. But that's like built up by me, and obviously with support from my parents. But I mean, if anything I wanted, I would get, as long as it was a book. So
Okay.
I got so used to, that kind of lifestyle, staying alone in my house and trying to read and competing with myself and how quickly I can finish a book.
Okay. So just sorry, this isn't in Copenhagen. This is where
In Nigeria.
Okay, so you're growing up in Nigeria, in the capital,
Yes.
in
No, it was in the southeast. It was in the
Southeast.
southeast of the country. Yeah, it was in the capital.
Okay. And this little boy who loves reading, so you're saying this wasn't particularly in your family's culture. This is just a passion of yours.
Well, it was my dad. It's like he
Okay.
had his own library, so it was more like he was, it's like a passing on of I love
Okay.
reading, so my kids have to love reading in a way. But it was in such a very smooth way that I didn't hate it. It was like growing up. If your parents insist you have to do something, something in your head goes off. Like, I can't do that because I have to
Sure.
rebel. But in his
Yeah.
own way, he made me enjoy reading in that way.
Okay. And were these books novels, fiction, or already something to do with
Fiction,
medicine or?
fiction, not fiction and non-fiction. I was reading social psychology when I was I think in high school,
Okay.
junior high school. For some reason, I found a huge book on social psychology, and I was like, oh, okay, I should probably read this. And I was
Okay.
reading that while I was still. So it was both fiction and non-fiction. I actually stopped reading fiction before I finished high school. I thought I was, getting tired of, listening to or reading stories over and over again. I wanted to like get into people's way of thinking and how they
Interesting.
perceive certain conversations and discourse.
Interesting. And forgive my ignorance, but what exactly is social psychology?
Well, that's exactly what I was trying to find out.
I probably should know. Sorry.
So it was, for me, when I was reading that, it was psychology of how to relate with people. It's like how,
Okay.
how to have those, understand people better, how to understand my environment, my social environment better. That was essentially what I was getting from that.
Okay.
What men react to differently, what women react to differently, experiments with, different primates and all of that. It was a huge book.
Okay, interesting. So kind of it was outside your normal kind of curriculum at school. It was just something that was already striking you as interesting and you wanted to learn more.
Absolutely. I had nothing that was going on in school that was close to social psychology.
Okay, okay. All right. And you were growing up with siblings or you were an only child or?
I was growing up with siblings, not the only child, but I mean, there was a Nigerian thing about being the only son.
Oh,
So
okay.
yeah, I was the only guy in the house. So I think that sort of affected me in a way because
Okay.
obviously going to school and then my classmates telling me they're playing, console games with their brothers. I didn't have that, right? So I didn't play console games with anyone. I played it alone most times. And I think one of those experiences where I was playing and my dad's friend, my dad came back from work. He came back with his friend who was a surgeon. And she goes, "Oh, your hands are steady. You should
Ah,
be a surgeon."
wow, how interesting. But your
So
dad,
that was it.
he wasn't in the medical
He
world.
wasn't. No, he wasn't. So
What
that
did
was it for
he do?
me. He was a professor.
Okay,
Um,
interesting.
yeah.
So, okay. And I'm really interested, you said that like the focus on the boy. Well, tell us a little bit more. What you mean it's like uh boys are prioritized ahead of girls or tell
Absolutely.
really?
So
Okay.
if you had a family and you don't have a boy, there's a perception that you're not going to be passing across your generation. It's like your genealogy, sort of like if you're a
Okay,
man, you and your wife don't give birth to a boy. It means that no one is going to carry your surname
of
on,
course. So your
and
DNA
then
might go with the girls, but it's not the same as the
basically.
name carrying on.
Yeah, so that was a priority, sort of like, especially in my culture, that, if you don't have a boy, that's not good. You're like, you have all girls. So that's why every family struggled to have at least one boy.
How interesting.
And then after that first boy, they want to try again to see if they can double it up, because you never know what's going to happen with that one.
Okay, heir and a spare. Yeah,
Exactly.
that's what they used to say about the royals, William and Harry, they were like the heir and the spare. But I'm just thinking maybe that was quite pressurizing as well to be this boy and this expectation. I don't know if how that felt for you. Like, I don't know what kind of
Hmm.
pressures were on you.
Well, I think that, for me, I think I wasn't thinking about, I think at that time I was pretty young. I wasn't thinking about the pressure of it. I
Yeah.
think it was only until I got into university that I was thinking about the pressure of it, like, how much is on me to achieve or to be exemplary so that I can, because I'm the only one, carrying this forward based on the tradition.
Sure.
Like, how does that affect how I read and how I study, or how great I want to be? And I
Yeah.
wanted to do that for myself and not do it because of, because of a particular thinking in my culture. But thankfully, my parents are very exposed. They did their best to make sure that my sisters understood there was no favoritism of sorts because I was a
Okay.
boy.
So they were quite
Um,
unusual for their culture to be like that.
quite in a way. But it's like we have a standard family who try to make sure that he's the only guy. He's the next head of this family. He's the,
Okay. Okay. So
a lot of.
you weren't completely immune from these kind of pressures.
I was not, but I mean, my parents did a lot to protect me from it. I think
Okay.
in so many ways, like even in terms of how I spoke to people that usually brought that up, I stopped in a way communicating with them. It's like it was always brought up. So I was like, I'm not gonna be in this space where it's gonna be
Yeah.
in the conversation a lot of times.
I'm really interested in that because I work with a really nice therapist, and one of the things I'm always working with her on is this idea of not looking for yourself where you're not. This is one of the things she's always talking
Mm,
to me about. So it's kind of like we're always looking for this outside approval and outside affirmation and like ticking boxes that other people say we're okay. And what I'm hearing from you, and maybe I'm wrong, but it sounds great that you didn't like you had quite a good sense of yourself without needing these other outside things to say I'm on track, Victor's okay. Victor feels he's okay
abs-
anyway.
yeah, absolutely. And I think, it's like I have a different kind of worldview to that. I try to apply some balance in every way that I think. I know that it's great that I'm not listening to what people are saying about how I should live my life, but I also know that sometimes we're stuck we're like a bug in a cup. We're stuck in that worldview of what we think of ourselves, and sometimes we need external perspectives to help us to expand that. So I'm just right there in the middle where I'm not really concerned. I'm not as much concerned about what people want me to be, about what people expect of me, but I also listen to them to see, what are the expectations out there of what an ideal Victor could look like, and see how that fits into my own understanding of myself.
That's nice. So it's kind of like lining up with what you want, but doing it from a position of curiosity, almost, of like kind of what's out there and what options are there, and like what different people could bring. So tell me a bit more. So you expressed this interest in psychology. You go to university and you're studying psychology, or you're studying medicine?
No, I went.
No.
Yeah. So once she came in and said, "Your hands are steady. You should be a surgeon," I wanted to be a doctor. Because at that time I was very good with literature, and it's like I was going towards the legal field. I was so into it, but I was also great with my biologies and my chemistries, and my counselors at school were giving me the options to choose which pathway I wanted to take. But she changed that for me, because as soon as she was done saying that, I was like, I'm gonna be a doctor now and become a surgeon.
And why was she so influential? Why did her voice carry such weight?
I just think it's in the way that she taught that she flipped it for me, because most times when people look at me playing the PlayStation, they think I'm distracted from my studies. But she came and saw me playing the game and said, well, because of this game that you're playing, I can see that you have potential to be a surgeon. It was so
no, I quite agree. I love that, because my son is forever playing. He I don't know about he's on a console, but he's always on his computer playing games. So maybe I'll try that with him, and I might end up with a surgeon. That would be nice. But so tell us more. So you go to university, you're not studying medicine at this point, but you've already got you are doing some medicine.
I went straight to medicine when I finished high
so
school.
after this lady, okay. So you qualify as a doctor. This is still in Nigeria.
Yeah.
Okay. And like a general doctor, you're not doing psychiatry or anything at this point?
No. I finished up from medical school. I did my initial internship, and then I practiced for 2 years.
As a regular GP,
as a GP, yes.
So in fact, not the surgeon that we thought you were.
Not the surgeon, no. I was thinking about it, but I think as at the third year in medical school, after the first major exam that I took, I passed. I was like, this doesn't look anything close to what I thought it was going to be like.
Interesting.
I started trying to. I was taking courses on. There's this global health space online that the WHO had at some point. I was taking courses on epidemiology, on communicable diseases, and just trying public health, just trying to see what else can I find within medicine itself. Like, I don't have to be a practitioner, right? So I was just trying to look for something else that would be interesting, because I was thinking, if I were going to spend the rest of my time in a clinic in the same place, come in every day and do the same thing over and over again, I'd probably pull off my hair. So I wanted to do something more. Right from when I was in my 4th year, I was telling my classmates and my friends, I probably wouldn't practice in the typical clinical way. Yeah.
Okay. So it's almost more like medicine as a gateway, as a kind of intellectual gateway to all these other disciplines and fields.
Exactly.
I get it. And that's interesting. So my daughter is a 4th year medic, and I'm just wondering where she's going to end up. She's a little like you. She's not sure. She's just taking a year to do neuroscience. She's done her 3 years training, and she's very open to suggestions and kind of different areas. But tell me a bit more. So when does mental health kind of enter the picture? So you're kind of curious. You're looking at all these different fields, as you say, world health, public health, I don't know how you ever say it.
Epidemiology.
Epidemiology. I should know that.
Yeah.
Right. So you're looking at all these fields, and then tell us about mental health, and because this is obviously, we're Inspire the Mind, and we're in our medical students are going to be psychiatrists, and this is our field.
Yeah, so while I was in my 5th year in medical school, I was diagnosed with depression and anxiety. And for me, I went to private university, by the way. So I was in a very protected environment. I had very good friends who were well exposed, who knew what I was dealing with. And they helped me through that. It's like they took me to the psychiatrist. I did group therapy sessions with them on board. So it was very, very I was carried forward. And that made it easy for me to actually finish medical school, because I probably wouldn't have finished medical school.
And sorry can we just go back one step before we go on? But what do you think triggered that anxiety and depression? Because we talked a little bit about this kind of quite a pressurized culture of the only son, high achieving. That's a little bit my story. I went to this very competitive school. I went to Oxford, and then I worked at the Times newspaper, and it, in the end, for me, it was very pressurizing, or it was how I responded to the pressure. It wasn't necessarily, it was more my response to the circumstances. But what do you think was going on for you that sort of led to this anxiety and depression?
I think it wasn't like a new occurrence for me. That was when I was diagnosed, right? So it was like, it took me a bit of time for me to come to a point where I recognized that something was wrong with me. I think right from when I was in high school, I had cut myself a couple of times. I had actually tried to kill myself like twice before uni.
Gosh.
And I can't tell you why. I can't for sure tell you what reason it was. Like, I have very loving parents, like doting sisters. Yeah. So it wasn't like I could possibly point out what it was, but essentially that's depression, isn't it? It's like, if I can't find a reason why that happens to me, and I always have the question, is what most people that actually deal with what we're dealing with, that's what they have as well. So I couldn't possibly tell you what it was. It's just, it took me a long time for me to get to a point where actually I had a breakdown. I think the core trigger for me was the loss I experienced in my 4th year, which was like very close to my exam. So I didn't have enough time to process it. So I just went straight, finished my exams and then went to the next year. Okay. That new year was like, I had to now reprocess that loss, which was so huge for me. I lost someone really
You lost a member of your family or a friend, or?
No, just a friend who was like, very amazing to me. And, it took me a while to get used to losing that person. So that was like the core trigger for that new relapse. And thankfully I was around people that could identify some of the symptoms I was dealing with. And they was like, we should get you to see a psychiatrist and get something, like get an assessment done, and so you can start your meds or start therapy. So that was my first experience with a mental health service, apart from my psychiatry posting, But when I finished medical school, I was already seeing a psychiatrist, and I went to see a psychiatrist one day, and he told me, it's like, my meds were not working to me. I mean, I thought they were not working, and I was having a couple of side effects. I wanted to get them changed. And he told me, after changing the meds, he gave me an extra diagnosis, like, you have mild OCD. And I was like, what exactly does that mean? And eventually, after the whole consultation was done, he said, you're a doctor, right? I was like, yes, I'm a doctor. He was like, you're very lucky. I was like, oh yeah, sure, thanks. And I left. I was angry. I was like, how does it make sense that you're giving me 2 extra medications to take? You've given me an extra diagnosis, and you think that I'm lucky. You think I'm lucky to be taking these medications. What wasn't working for me, and I came to you, and I'm telling you to change my whole structure of my treatment. You added a new diagnosis. Like, how does that make me feel lucky? So I called my friends, and we destroyed him on the phone. I mean, obviously, within ourselves, like, oh, he's shit. But I called my mom, and she said, just giving you a different perspective here, possibly when you were in medical school, I remember you telling me a couple of your mates who killed themselves. I remember you telling me a couple of your mates that dropped out of medical school because of something that happened to them. What if it was their mental health? And it, that sort of like, it calmed me down. So I started thinking about that, thinking, it looks like I'm very privileged. I'm coming from a very privileged perspective of having people who were that kind of community for me.
Yes.
Is that the same for every young person in Nigeria? So that was what got me thinking. And I was like, I need to check it out. So I did an informal scoping review online and offline, had calls with some psychiatrists, some of them my lecturers and professors in school. And I did some search on Facebook and Twitter and Google to find out if there were existing structures and organizations that were doing something, they were delivering programs the way that I was thinking about solving that problem. And I didn't find any that was like, to my own liking. So I thought, I need to create something.
Right.
But what happened was, even when I thought about creating something, it wasn't something I wasn't thinking long term. I was like, just build a community of people that have similar conditions, and we can have a chat, we can get to know each other, and we can be there for each other. That was my initial thought. But eventually, when I got to registered with the support of my friends, and then we started doing like conversations with a couple of people who were interested in being a part of like a membership. And then we started training ourselves and training others, and started getting ready for launch. 6 months later, we launched. And I'll tell you, Nigeria, like the stigma level in Nigeria is really high. It was so much more higher at that time.
Right.
So, but we got a lot of people actually interested in the conversation. And how did we do it? We thought, instead of doing it the way that people usually did it in the past, let's try and make this a cool concept to chat about. So my friends and I were pretty young, and we thought we were pretty cool. So we thought.
Hang on, what date are we, by the way? When is this all happening?
This was in June 2016.
Oh, so pretty recently. Wow. Okay.
Mm-hmm. This was in June 2016 when we launched it, and was like, let's make it something that people would feel that sense of, community, but also that sense of, I want to be part of these guys. They're doing something cool. I want to be part of this group.
And what's it called, the organization you founded?
It's called Mentally Aware Nigeria Initiative.
Mentally
Aware Nigeria Initiative.
Mentally Aware Nigerian Initiative. Okay.
So it's Mani for short. So we call it Mani.
Okay. Okay.
Yeah. So that's how Mani started actually in 2016. And, we had such a huge growth in people engaging with our work, but we always thought that we don't want to be creating what is just in our head. We've got this experience, done a couple of trainings, but that's not enough. We want to learn how people want to be engaged. How would you like to be engaged? So we actually organized the first physical event in October 2016, where we had about 300 young people, which is amazing for us, on a rainy Sunday, come together, sit down, and actually help us co-create our strategy as to how we wanted to operate. At the time, I had no idea it was co-creation. I just knew I wanted, it's like, if I'm creating something for a particular group, I feel like they should impute into it as well. And that was the direction that we went.
But the initiative was to support other people finding life difficult. So your insight was, let's do this in a collaborative way and ask people how that might look, rather than just me, Victor, saying my way or the highway.
Exactly. So we had that perspective to create a community for people that, wanted to be there for each other. But when we started asking questions as to what young people would like to see, they thought that it would be great if we had, like a good focus on awareness raising.
Sure.
And make sure that we are very focused and very consistent, because that was what was lacking at the time, was that there was nothing consistent about how mental health awareness was done in Nigeria. There was nothing consistent about it. So after that initial events that we had, every month from November 2016, we focused on a particular mental health condition, and we exhausted it. When I say exhausted, we talked to service users, we talked to specialists, we went through all of the literature on it. We talked about how you can seek help, how to have a chat with your psychiatrist about, your symptoms of depression, everything.
You looked at depression, anorexia, bipolar, psychosis, schizophrenia. You would just take all the conditions, and where are we at right now?
So we're taking it like one a month. So depression would take November, bipolar disorder would take December, January was addiction, February was self-harm, March was suicide.
All online. This is all, people
all online.
Okay.
At the time, all online. Yeah. Okay. And eventually we also just, most of the things that we did, we learned while we were operating. And what we saw was, while we were raising awareness, the unintended consequence of raising too much awareness is that people will reach out to you for help. Because now you've said, I have this, you said you put some symptoms up that look like what I'm dealing with. How do I get help? Yeah. Right. So that's an unintended consequence of, putting so much focus on awareness. And what we did was we found that out. And what we did was we started to build out a strong referral platform that allowed us to refer people to services when needed. But we also saw that some people needed less intensive psychological support. So we started training counselors and listeners who we're going to be on it's like, set up a toll line that people can call if they need to have a chat with someone, but it wasn't free. So we couldn't, set up a toll free line because it was resource intensive. And what we thought was, let's use WhatsApp and do it, text based. So we switched to WhatsApp and switched to text based platform, which is probably the most important decision we made over the past 5 years, because since then it's been our most used service, because that service has provided over 40,000 people relief from their mental health concerns.
So they could WhatsApp and then they would, and who's funding the counselors or the people speaking to these people?
No one. It's a volunteer based. We train them. Voluntary based. We train them. They provide the service over text. I think if I'm based on our last impact report, that service has given more than 6 million minutes in terms of commitment to people that have reached out for help.
Okay, well, congratulations. That's amazing. 40,000 people. But Victor, can I just go back a little bit? Because there's just so many things going on there. Just back to your story. And you said that, life was tricky. You had this diagnosis of anxiety and depression, and then you were given another diagnosis of OCD. And you felt that wasn't necessarily helpful. So are you saying that, well, I just wondered, what, are you saying that we overdiagnose, we come up with things that aren't necessarily true? And where does that leave medication? I just back to your story.
Yeah, so I always like to keep a very balanced perspective when it comes to medication versus anti-medication, as someone who is like both. I've been from a clinical perspective, but also from a user perspective. Yeah. It's that, like, so many things, like at that time I felt it was too much for me to be dealing with, like, you're labeling certain things that you've seen and you're giving me about 3 different diagnoses. I didn't think that was helpful for me at the time. Yeah. But the problem with that is because, like, right now I've done the research, I've gotten into the research perspective of it. It's like, I feel like the language that we communicate mental health is very much imported from the West. It's like, we don't have anything formulated locally. And there's an example that I gave people is, if, for example, the DSM-5 or the ICD-11 was created in Lagos, Nigeria, will we have psychiatrists in the UK and the US using it to diagnose their users, the patients? I don't think so. I don't think they would take it. I feel like we have taken on a lot of imported language when it comes to mental health and diagnosis and classification. And that's very difficult for people in our context to understand. And even some of the things that we find common in our context, in the DSM-5, they are seen as culture-bound syndrome. It's like, we're not just the only ones with the culture. I feel like the guys in the US, like, Americans have their own culture. British people have their own culture. But why don't you guys have your own culture-bound syndrome? So I feel like the language of mental health has been so skewed towards what exists in the West, where the research is and where the capacity and where the power is. While in the South, for us, like, it's so difficult for us to be the ones to start having conversations about, let's go down to the grassroots. Let's start to build a foundation for the language of mental health from the scratch. Let's talk to a grandmother and ask her, how are you feeling when you say your mood is low? And reshape that from the scratch up to the diagnosis level.
So you'd almost like a whole new way of diagnosing that's more in tune with local conditions and culture.
I would even go down to diagnosis, because maybe diagnosis in its way, diagnosis of mental conditions in its way is also, like, we're already going to, I feel like we're already, like, making conclusions and assumptions that we shouldn't be making yet. I feel like we should first of all explore how people feel and how they interpret how they feel, and basically, bring that back home. Like, if we start from the language and start to design what are the different ways that people possibly translate low mood? What about people hearing voices? What exactly is bad about hearing? It's like just really coming from a non-assumptive point of view and building that from the scratch before we get to a point of labeling, because there's so much problem with labeling certain conditions, and I don't want to go into that. But that, that's what I want to define diagnostic aspect. But eventually that could happen. We could end up building like a classification system that allows us to explore the social and environmental factors that affect mental health, the social determinants of health that we can, include into the conversation of mental health in the South, which doesn't exist. No one considers poverty in the way that it affects us, it's like most of us in the South, no one considers that in the diagnosis for mental health, like
Yeah.
conditions.
Yeah.
It's very
Different
biological.
order. It's a, yeah, as you
Yeah.
say, it's a completely different order. And I mean, it's a huge topic, isn't it? That the conditions are completely different. But that's very interesting. And that at the moment, other doctors in Nigeria are not questioning the taking, wholesale a Western approach.
I don't think so. I feel like what happens, I mean, we don't have so many psychiatrists in the first place. We have less than 200 psychiatrists.
200.
200 psychiatrists in the whole country, yeah.
And how many people in Nigeria?
It's about 200 million people. So it's like one psychiatrist a million people.
Okay. So in a way, that's very interesting. In a way, you've got to challenge everything. You have to challenge diagnosis, but you're also going to challenge treatment, because if you've only got 200 psychiatrists in a country of 200 million people, I mean, how's that going? I mean, I didn't even understand.
Yeah, no, that's a lot. I mean, but that's why we need to start thinking about, like, what are the low intensity psychological interventions that are population based. What are those non-typical psychological interventions that actually are clinical? Like, there's some things that have been tested in India and some parts of Asia, like cash transfer and how it affects suicidality. It's such a hugely effective intervention that we say suicidality reduced in the population, on the population level, with increased cash transfer programs.
What, just to make it easier to be able to access cash, that actually reduces levels of people taking their own life?
Yes, making it easier for people to actually have money at hand to feed, themselves and take care of the problems. That reduces suicidality to a huge, I mean, the data is out there. So it's like, we should stop looking at things from a very core biological and clinical perspective, but we can get clinical outcomes from considering other spaces, like the financial, the environmental, the physical, the psychological, and the social.
Yeah.
Like, it's all related in a way.
There's an interesting work of writers like Johan Hari. I don't know if you've read him, and he's very interesting about a kind of societal understanding that a lot of anxiety and depression is a normal response to challenges in society. It doesn't necessarily make it kind of like a medical, biological condition. That's a big debate again.
Yeah, I mean, I would agree to disagree, because I feel like, yes, we are pathologizing a lot of conditions that are normal responses to normal situations in life. That's happening. But actually, that doesn't discount from the real experiences of people who experience things that they can't explain with typical environmental, triggers. I feel like we tend to always look for extremes of perspectives, but sometimes the answer is right there in the middle.
Yeah, so that's a nice kind of balance, that while there is a societal element, there is also a biological element, and it's actually these 2 points. You neither one nor the other dominates. Yeah. And tell me, I'm just watching the time. I know we have a little bit more time. That's good. Tell me a little bit more. I'm really interested about these kind of maybe non-medical approaches or interventions, as you say, clinically based, with a very big population with very little medical support. What other things are helpful for people, or low cost interventions that might be able to support people's psychological health?
I mean, there are some structural interventions, like systemic interventions, that are well recognized. They have the evidence and they can be done at scale. You have the WHO, the World Health Organization, MHGAP, mental health gap intervention, and that trains non-specialist mental health workers to be able to diagnose and treat mental health conditions at the early level, at the early stage of diagnosis. So let's say, let's use Nigeria as an example. We have a primary healthcare, a secondary healthcare, and a tertiary healthcare. Mm-hmm. At the tertiary healthcare level, we have less than 200 psychiatrists, but we have a lot of community health workers who can be trained to actually identify mental health conditions and treat it. So let's say if I was like coming in with somatizing symptoms like, oh, I have a headache, it's like it's coming every day, they should be able to assess me for depression or anxiety to make sure that I don't have mild or moderate, anxiety or depression. And if I do, they can recommend low intensity psychological interventions like PM+, like, IPT, like, interpersonal therapy. They can recommend those without considering medication. Now, if I get to the stage where I'm experiencing symptoms of, say, moderately severe depression, they can then refer me to the secondary healthcare center where I can speak to a doctor who is not a psychiatrist, who is a doctor that can prescribe medications for me, right?
Mhm.
So the only time I get to see the psychiatrist at the tertiary level is when I have a severe condition, when I start hearing voices, or I have psychotic symptoms, or I have drug reactionary symptoms, or drug addiction. So it's like, that's the time when they can refer me to those people. And that reduces the number of people that go into the tertiary healthcare center and crowding it out and putting so much pressure on those psychiatrists, which I feel very few of them, to do
Sure.
their work. So that's like, a pathway for care that works in so many settings, but so many governments are so reluctant to scale.
Interesting. And at the moment, so like primary care, would that not be something that they're looking for at the moment? They're not really looking at psychological issues?
No, not necessarily. In fact, no. In some states in Nigeria, like in Lagos State, maybe they, sometimes, I would say sometimes, just maybe about 3 states in the country would have something that looks like a primary healthcare system that looks at mental health. And it was done as a pilot of a research by some individual who wanted to pilot something like that. That's the only time such a thing was done. In Benue State, in Lagos State, I think it was also done. So it hasn't been scaled.
Right. And
And
is that about lack of resources, or we touched briefly on stigma, or what's going on that it's not a priority?
it's a lack of political will, and it's a lack of political education on what kind of policies are effective for mental health. It's a lack of interest of politicians to think of mental health as a core component of their promises, or like of the kind of projects they want to do. And it's also because of the lack of interest of the population to push for those changes at society at the structural level, because of stigma, because of the lack of understanding of mental health in the community. And that lack of understanding can be related to as well to the language, the important language of mental health. Because if I don't understand something, there are 2 things I could do. I will either fear it or reject it. If I don't understand it, I would mystify it, and it becomes a mystery to me, and I'll be afraid of it, and I will definitely reject it. And that's normal.
So underneath it all, you feel like it's a lack of understanding.
Underneath it all is a Western, it's the Western, it's like the colonization component of it. It's like how much of it we've taken from the West, and how much of it becomes difficult for us to understand and translate locally, in a way that people can relate to it. If people don't understand what you're saying when you say you have depression, if my grandmother doesn't understand it, she's not gonna let me take it. It's like, it makes sense. They want to protect me from such a mysterious thing, which can be a curse, which can be something that is not necessarily in our generation, or in our family, that anyone experiences that. Like, that's something we should push away from us. And that translates to even the politicians themselves, because they can't create policies about things they fear.
I understand. So it's interesting because some of these issues are obviously also relevant in the UK, like mental health, a poor relation of physical health, and that's been around as well. And it's something that maybe is shifting now. But could you just give us an example of like a more nuanced and relevant conversation at that primary care level that would explain a mental health in this different kind of, as you say, not the Western way of discussing it? How would that discussion sound?
I think that Friendship Bench in Zimbabwe gives you like a very classical example of what a localized intervention should look like. It's my grandmother sitting down with me and asking me what the problem is, asking me, like, giving me very concrete tips about how to handle a particular problem using problem management first. And that's a whole different thing. It's like, I have someone I respect, I have someone who I've doted on from when I was a child, and they're having a chat with me about a particular thing that I'm experiencing, which I couldn't probably tell anyone else, right? Like, that's a very nuanced perspective. It's a very localized intervention that allows young people, old people to actually express themselves in the way they understand. So like in Friendship Bench, they have something they call Kubatana.
Sorry, what's
I'm not sure I'm saying it right. Friendship Bench.
Sorry, I don't know. Tell me about that. What does that mean?
So the Friendship Bench intervention is basically was set up by Professor Dixon Chimbanda. And the way that it works is it's basically a bench
Sure.
And you have a trained grandmother who was trained in PM plus and active listening. And they sit down there, and if you have a problem, you want to have a chat, you're dealing with a particular condition, you just go and sit down on the same bench and you have to chat
Sure.
with them.
Oh, actually, I have heard about this. It's
Yeah.
absolutely wonderful. And I find that so interesting that it isn't just what you're saying, it's also who you're having the conversation with, and that feeling of trust and safety. And maybe that's interesting. Maybe there's something there about a kind of respect for elders. I don't know if that's a more cultural.
Absolutely. It's very cultural, yes. So that you can see how much that intervention takes in culture
Yeah.
of the population. Yeah.
Because I think maybe that's something in the West, we don't have so much respect necessarily for older people. You know, we put them away in nursing homes. I don't know, maybe, have you read any of the Atul Gawande work? Have you ever read him? He's
No.
African-American doctor, and he's very interesting about different cultural approaches, and particularly America compared to Africa, especially in terms to elder people and respect to elderly people, and also attitudes to death. But that's one of the points he makes, is a very different feel about respecting elders. So that's great. And any other ideas? Because I find it fascinating of these different approaches.
Yeah, well, I think the conclusion of everything would be meet people where they are. Like some of the interventions that I know that have worked in Africa, and even in India. In India, there's another intervention called Atmiyata. They meet people where they are. It's like they have these community workers that they've trained, and they go house to house to offer counseling and mental health support. In South Africa, you have Ways for Change, and it's basically like what do you call it? Like, it's basically done by young people who I'm forgetting what that's called. It's like
yeah. And sorry, what was the name you mentioned earlier? You said it was called, I didn't quite catch what you said. Atmiyata. Atmiyata. And that's something you said in India. So it's meeting people where they're at.
Yeah, basically, I think most of the things that have worked, most of the programs that have worked meet people where they are.
And that
so
means,
I was giving you examples. An example is Atmiyata is one of the programs that I know that meet people where they are. They have counselors going to different homes in a particular community and helping out, right?
Yeah.
For South Africa, I was giving a different example. They use surfing therapy. So they have these young people who love to surf, and they teach them how to surf. And while they're doing that, they're having like good conversations with them. In Uganda is Strong Minds, and they bring women together in a group, women dealing with depression, and teach them how to make, it's like it's like small businesses, really, like how to set up small businesses and all of that, while doing interpersonal therapy as a group. So like you have these different things. Like in Nigeria, for us, like it's basically we have a conversation cafe where, like I said, we've gone with a cool band. What we do is we bring young people together at the beach, in a very lush restaurant, fancy restaurant, like all of that at the park, and they all sit down together and we have a chat about mental health, but not in the typical "what is schizophrenia?" No, it's basically, let's talk about mental health and your relationship. Let's talk about romance and mental health. Let's talk about, it's like, what mental health movie do you enjoy watching, and what did you feel about that? It's like very simplified conversations that allow people to express themselves in very effective ways. So it's like much of what should work would be very context-specific programming that is focused on the target population and brings that intervention to them wherever they are.
Okay,
whether
so
it's
rather
online
than like
or offline.
going to a clinical environment, you come to them.
It's community-based, really. It's like community-based interventions are the way to go, I would say.
Because it's interesting, because a lot of what you're saying, I don't see why it's not just as relevant to the West. I mean, yes, of course it does reflect a different culture, but actually I think a lot of things, there's a kind of common humanity as well.
Absolutely.
And, we've developed a certain approach in the West, but maybe we've lost some of that community-based, localized kind of interventions, which I think are very attractive to a lot of people. I mean, I'm thinking, wow, I wish I'd had some of that, And I think there's something about kind of normalizing the fact that it's happening in everyday life. It's kind of where life's going on anyway. And so it's not like mental health is out there. It's actually here. It's part of all of us. It's part of our community.
Yeah.
How amazing. So, and this is going to be your work. This is like your full-time job, running this organization. And
well, not anymore, because I think we've gone to a point where we could hire a director, who's very, very well experienced, and she's doing that perfectly. We have a whole team doing the whole stuff in Nigeria. Right now I'm in Copenhagen, and I work with the MHPSS Collaborative, which is hosted by Save the Children in Denmark. So that's where I am now. Last year, I was with United for Global Mental Health in London. So I was there for like a year and a half. And
so you're working for Save the Children right now? Well,
I work for like it's like an organization that is hosted by Save the Children right now.
And that's focused on mental health,
on children, and so it's focused on mental health innovation and research, and events and climate change, all of it. Like, how do we relate climate change and mental health? How do we relate education and mental health? How do we relate livelihoods and all of it, like with mental health?
The organization you're with now?
It's the MHPSS Collaborative. So it's mental health and psychosocial support collaborative.
Mental health and
psychosocial support collaborative.
Wow. Mental health and psychological social collaborative.
Psychosocial support
collaborative. Okay.
Yeah.
Okay. And so that's where your focus now is, and again, particularly with young people though.
Yeah, absolutely. My role is in youth engagement and MHPSS.
Okay.
And I've been doing quite a lot of like trying to build out what we want to see next year in youth mental health globally, who we want to collaborate with, and a couple of very interesting, hopefully interesting things.
Yeah. And do you think it's that young people want to talk to other young people? They want to talk to cool young people, or what's the priority there?
I mean, for me, the priority right now is really just policy, policy agenda setting at the high level. We need more funding for youth mental health globally. We need more attention on it globally.
Sure.
We need more commitments by, huge like governments. We need to have youth mental health in conversations by the UN Secretary General and it's like the World Health Organization. We need more globally based interventions, right? So now my perspective is very much global. Like, how can we influence policy at the high level, and how does that trickle down to the national and regional levels?
Okay. And have you rung Mr. Boris Johnson?
I have not had any conversations with him, no.
No. Okay. Well, I think I'm watching the time. Yeah, I think maybe you should give him a call. So many interesting things to say. But yeah, I think, look, I salute you, because obviously, like, prevention is better than cure. And if we can get to young people, and we all know, I think it's half of mental health conditions present,
Absolutely.
By the age of 14 or whatever. So obviously makes sense on every level. Yeah. So fantastic. So that's what you're doing right now. Well, like, fantastic. I congratulate you.
Thank you.
So and just thinking, we call our sort of conversation Inspire the Mind. And with all this incredible work that you're doing and have been doing, what really kind of inspires you? What inspires you to keep going? What inspires your mind? It's I just wondered if there's one thing that just sort of drives you. Obviously you've got your own personal experience, but what really inspires you?
I think it's that a lot of the solutions they were looking for are right. It's like they are home with us. Like, there's not so much that we've done that we've had to take from outside. And that really gets me going about what's the next exciting thing that we can find and, resurrect from my experiences at the local level. Like, for me, when I started the organization, I learned a lot from some of the things I watched my dad do. Because as my dad is a clergy, and a couple of times he went to places where they were not familiar with the religion, right? And he spent maybe 6 months. Within 6 months, he's planted a church. He has people that are happy to take care of the church, and he's moved on to the next place. And that to me was advocacy. That was awareness raising at the highest level for me, because I thought if someone could come and it's like have a conversation about completely unfamiliar concepts with a particular number of people, and actually convince them enough to get to the stage where they can, have their own place of worship and be able to manage that on their own. There's nothing more interesting than that. So why can't I do that for mental health, right? Like, why can't I have such a benign concept become something that people consider mainstream, right? So that's sort of like, it's the work that inspires me. It's how much more work there is to do, it's how much more we can actually do at the ground without taking any perspective. There's nothing wrong with learning from people, but without importing that, right? Like how that keeps me going a lot. One of the things that keep me going. Yeah,
that's lovely. It's almost like you've already got the answers within you. They're kind of there.
Basically.
Yeah, and sharing them with others. Well, thank you so much, Victor. That's been really wonderful. It's fantastic to hear what you're doing, and really made me think in so many ways. So no, it's been really wonderful. Victor Ugo, thank you very much for having and joining us on Inspire the Mind. So thank you everybody for listening. That's actually our last interview for season 2, and we are going to be back in 2022. Can you believe it? With season 3, with more guests who will make us think about all these incredible issues and how to inspire us. And I think Victor has just done that so well. And thank you very, very much once again, Victor.
Thank you.